So I'd say in the last, I don't know, 5 years or so, probably the fastest growing segment of our diagnostic MSK practice has been imaging the digits, the fingers and the toes. And this lecture is going to focus on finger injuries. So in terms of an outline, we'll talk a little bit about technique, the unique anatomy of the fingers, and then a spectrum of traumatic pathology in the fingers. In 2014, at the very least, you should be using a dedicated wrist coil with fields of view in the 6 to 8 centimeter range generally. For your fast spin echo sequences, usually about 2.5 millimeter slice thickness for the 2D. For the 3D sequences, 1 millimeter or so. And our standard protocol is to use a T1 weighted fast spin echo and PD fast spin echo sequence, with a TE on the intermediate weighted sequence being down in the 36 range to make sure, as Bill showed in his lecture, as you come back on that T2 time decay curve, the signal to noise improves significantly. Since you're imaging these small parts using a TE of about 36, it gives you a good balance between still having enough T2 weighting and having adequate signal to noise. If you've got these MR microscopy coils available, which I showed you yesterday, this is a great application for them. They kind of approximate the size of the finger, and it's easy to see why you end up with very detailed, high-resolution imaging of small parts like the digits. This is a patient who has an erosive form of osteoarthritis involving the DIP joint. You can see the central erosions, the marginal erosions, the subchondral cystic change, the marginal osteophyte formation that's typical in this disease process. So let's talk a little bit about the unique anatomy of the fingers. You've got this fibroosseous tunnel that's crucial for being able to attain flexion of the fingers. There are 3 cruciate pulleys and 5 annular pulleys that are thickenings of this fibroosseous tunnel. Fortunately, out of these 8 structures, there are really only 2 that are critical for maintaining flexion of your fingers. That's the A2 pulley at the level of the proximal phalanx and the A4 pulley at the level of the middle phalanx. These pulleys attach to the palmar periosteal surface of the phalanges. And then in addition, another structure that we see that's kind of part of this fibroosseous tunnel on the palmar aspect of the fingers is a fibrocartilaginous structure, the volar plates, which can also tear, rupture, displace, similar to the problem you can get with plantar plates in the toes. If we look at an artist's rendition at this fibroosseous tunnel, again, we're just going to focus on the A2 pulley, shown here at the level of the proximal phalanx near its base, and then the A4 pulley, which is located here at the level of the middle phalanx. As the length of the finger increases, the length of the A2 and the A4 pulley overall increases as well, as seen on cadaveric studies. So these pulleys may actually persist in the axial plane over multiple slices, depending how long the digit is. On the dorsal aspect of the finger, you have this dorsal extensor hood mechanism, and the word hood is kind of thrown in there because of its morphology. Centrally, you have the extensor digitorum communis tendon, which is colloquially usually just referred to as the central slip. Then there's a fanning out of the extensor mechanism called the extensor hood proper. Sometimes difficult to see directly, and usually we look for secondary signs of injury, are the sagittal bands, which essentially maintain the position of the extensor mechanism centered on the metacarpal head. So when these get torn, you usually get subluxation of the extensor mechanism one direction or the other at the level of the metacarpal head. You then have the lumbrical muscles. Remember, these are the only muscles in the human body that have a non-osseous origin and a non-osseous insertion. And then also the dorsal and palmar interosseous muscle insertions that contribute to the extensor mechanism. With MR microscopy, you can really see very nicely and directly the detailed anatomy of the fingers. So it kind of gets more like reading a large joint, when you're using these sorts of coils. Here's an axial image, intermediate weighted at the level of the A2 pulley. So here we're at the level of the proximal phalanx. You see this sling that's wrapping around the flexor tendon apparatus. You can see the extensor hood mechanism and nicely see why it's called a hood, the way it fans out here dorsally. The central slip that's located here. These little flow voids are the little digital neurovascular bundles, and this is the place where little neurogenic tumors are actually not unusual in the digits. It can be quite painful. A little more distally at the level of the middle phalanx, here we see the A4 pulley. So this nice little sling that wraps around the flexor tendon apparatus and is very important in being able to attain flexion of the digits. Again, here's the little neurovascular bundle and part of the extensor mechanism. Shifting over from the unique anatomy, let's talk a little bit about a spectrum of pathology. We'll start out with traumatic osseous injuries. So radiographically occult fractures, similar to what John showed in the wrist. You can pick up these fractures very nicely with MR, bone contusions, and then the spectrum of osseous stress injuries. This is not an osseous stress injury. This is a patient who was playing basketball and got submarined and came down with their thumb jammed right into the blacktop. Dislocated the thumb. Hand surgeon was kind of called into the ER to evaluate this patient because the ER physician could not reduce the thumb. Now, remember when we're interpreting MR for orthopedic applications that the ABCs, the very, very first thing we learned in terms of interpreting plain films in radiology, still apply. It amazes me how often there's no discussion of the alignment of joints, valgus, varus deformities in the knee, hindfoot valgus in the ankle, straightening of the cervical lordosis. The A needs to still be in the report. Just because it's not a plain film doesn't mean we ignore alignment. Now, obviously, in this situation, the alignment is obvious. There's a dislocation of the thumb here radially. But the reason the MRI was done was to figure out why this thumb couldn't be reduced. When we look in the coronal plane, intermediate weighted with fat suppression, first of all, we see the dislocation. We see the bone marrow edema from bone contusions involving the first metacarpal and the proximal phalanx. In addition, we can see that both collateral ligaments, the ulnar and the radial collateral ligaments, are completely torn. And then finally, we see the cause for the inability to reduce this dislocated thumb. It's this fibrocartilaginous structure sitting here and here, which is the volar plate, which is torn and interposed between the first metacarpal and the proximal phalanx. So a lot of very useful information to the hand surgeon preoperatively to understand what sort of reconstruction is going to need to be done and why it was not possible to reduce that thumb clinically. I mentioned that you can think about fingers now as being, kind of larger joints. So instead of ignoring what's going on with the articular cartilage in these, you can look for osteochondral injuries, you can look for intra-articular fractures, and you can look for chondral defects. This is another jammed thumb mechanism of injury playing basketball. And here we can see this 6 millimeter impacted osteochondral fragment. Okay, it's like a punch fracture here where the osteochondral fragment has been driven 2 to 3 millimeters up into the proximal phalanx here. We can also see the collateral ligament injury here ulnarly and the sprain of the radial collateral ligament as well. Drilling down even further, we can see isolated chondral defects. So here's the gray signal intensity of the normal hyaline cartilage in the first metacarpal phalangeal joint. This is a full thickness chondral defect as a result of jamming the thumb. Moving from osseous and cartilaginous injuries over to ligament and tendon pathology, we've got collateral ligament injuries, including the Stenner lesion. We've got injuries to the flexor and extensor tendons. MR is especially important where there's a closed injury that may be not obvious clinically, the underlying tendon pathology. But it's also helpful when there's lacerations and that sort of thing that extend down into the tendons. Not only useful in the preoperative setting, but it's not unusual for these patients to develop recurrent tears of the ligaments that can be evaluated postoperatively. And then we've got these pulley injuries that result in a bowstringing sort of appearance that we can also see with MR associated with injuries to the A2 and A4 pulleys. So some examples, we'll start out with skier's thumb. After upper extremity dislocations, this is the most common injury that we see in the upper extremity. In skiers, it's a disruption of the ulnar collateral ligament at the level of the first metacarpal phalangeal joint. When the tear is displaced superficial to the adductor aponeurosis, it's referred to as a Stenner lesion. So interposition of that aponeurosis with the ulnar collateral ligament flipped superficial to it is a Stenner lesion. And that's present in the literature somewhere between 15% and about 60% of patients that have a tear of the ulnar collateral ligament. Why is that important? Well, non-displaced tears of the ulnar collateral ligament can just be treated with immobilization, whereas the displaced tears require surgical takedown and repair. And MR is very, very useful to distinguish between these displaced and non-displaced tears. Some examples, so here's a couple of non-displaced ulnar collateral ligament tears. Coronal intermediate weighted image. Here's the adductor aponeurosis. There's nothing that's flipped superficial to it. Here's the ulnar collateral ligament coming up here. Here's the tear right at its phalangeal attachment. Non-displaced ulnar collateral ligament tear. Another patient, coronal plane, adductor aponeurosis. Here's the ulnar collateral ligament, which is torn here. Axial plane, adductor aponeurosis, tear of the ulnar collateral ligament that's not displaced superficial to the adductor aponeurosis. Another non-displaced tear on MR microscopy, intact radial collateral ligament, tear of the ulnar collateral ligament at its phalangeal attachment. Here's the adductor aponeurosis. This is not balled up and flipped superficial to it, so it's a non-displaced tear. Here's an example of a Stenner lesion. We get a finding that some people refer to as a yo-yo on a string. So coronal intermediate weighted image without and with fat suppression. Here is the balled up, rolled up, torn ulnar collateral ligament, which is displaced superficial to the adductor aponeurosis. So there's the string. Here's the rolled up and balled up displaced ulnar collateral ligament. Another patient on MR microscopy, coronal intermediate weighted image. Here's the adductor aponeurosis. That's the string. Here's the yo-yo, the balled up, torn ulnar collateral ligament that's flipped superficial to the adductor aponeurosis. On the other side of the joint, we can also get tears of the radial collateral ligament in the thumb. They're much less common. This is a 45-year-old agriculture worker in the Imperial Valley in Southern California who had an injury to the thumb. Pain and tenderness along the radial aspect of the first metacarpal phalangeal joint. These are coronal T2 star weighted images that nicely show an intact ulnar collateral ligament, but the metacarpal attachment of the radial collateral ligament here is torn. So the coronal images, here's the axial images, here's the tear of the radial collateral ligament. The ulnar collateral ligament was intact. These radial collateral ligament injuries also occur in other fingers. Importantly, in the index finger, this generally represents surgical disease when it has a full thickness tear. Here's another basketball injury, jammed index finger, coronal T1 weighted and more T2 weighted image with fat suppression. This patient was not responding to cast immobilization or actually was splint immobilization of the index finger. So the MR was done. And you could see that the radial collateral ligament comes down here, and then there's a full thickness tear and detachment of its metacarpal attachment. You got some joint fluid kind of going out also through a capsular injury into the overlying soft tissues. Another patient with a radial collateral ligament tear involving the index finger. So here's the thumb, coronal images. Here's the radial collateral ligament coming down, and there's a full thickness tear of its metacarpal attachment as a result of a fall on an outstretched hand mechanism of injury. Axial images in that patient. Here's the torn radial collateral ligament. T2 star weighted image. Nicely see just complete absence, increased signal intensity where you would expect that radial collateral ligament. And as I mentioned in the index finger, this is usually going to represent surgical disease. This is a small series from the Journal of Hand Surgery, a dozen patients, 3 of them that were immediately repaired, 9 of them actually had delayed repair following conservative therapy. So this is a type of injury that can either be repaired acutely or in a more chronic setting. The repairs were done using a little suture anchor, more common to avulse the metacarpal attachment than the phalangeal attachment, and in no cases were there mid-substance tears. So one of the 2 attachments usually avulses in this situation. And they had very good outcome following this stabilization procedure. Moving over to flexor tendon injuries, as John showed in the previous lecture, there's a zonal description of these flexor and also for extensor tendon injuries. You should know that the zone 2 is frequently referred to as no man's or no woman's zone, and the reason for that was that early on in hand surgery, there really was not a good procedure for doing primary repairs. So the retracted ruptures at the zone 2 level actually didn't do well. But there are now, with current surgical techniques, even zone 2 tears can be repaired primarily by the hand surgeons. So we'll look at some examples. This is an attorney who is also a very accomplished big rock wall climber who had an injury involving his ring finger, and you can see following conservative management he wasn't getting any better. These are sagittal contrast enhanced images. You can see the enhancing tenosynovitis throughout the ring finger. You can also see it looks like there's evidence here of a little bit of a split going on, so little tiny subtle longitudinal split, enhancing tenosynovitis, and also a pulley injury, which we'll talk about a little bit more going on here. So a combination of a subtle flexor tendon abnormality, tenosynovitis, and a pulley lesion in a rock climber. Going over to lacerations, this is a lumberjack who was up in Marin County in Northern California. He was strapped to a tree, had a chainsaw going, slipped and started to fall, and he grabbed the end of the chainsaw that was still moving with his hand, got a pretty bad laceration in the hand. He said he went to a doc in the box up in far northern part of Marin County, and they closed up the laceration, not realizing the extent of the tendon injuries that he had. So fortunately, he had a brother down in the desert and said, you know, I can't really flex my middle finger, my index finger, and so he came down, and the hand surgeon sent him for an MRI right away, because these are kind of a semi-urgent case to evaluate. And you can see in the axial T1 weighted images, first of all, when we look at the index finger, while the superficialis component of the flexor tendon apparatus is intact, the profunda part is gone. Okay, there's non-visualization of it here. And then for the middle or long finger, both components appear to be absent. In the sagittal plane, when we look at the index finger, we can see that the superficialis component inserts normally on the middle phalanx, so it's intact. But the profunda component, when we come up here, we see that it's lacerated here at the level of near the distal interphalangeal joint and retracted here almost to the PIP joint level. So that's the index finger. For the middle finger, both the profunda and the superficialis are involved. So when we look at the profunda tendon, which inserts out at the distal phalanx, we follow it down here to about the level of the A4 pulley. It's lacerated. You can see here's where the repair of the soft tissue laceration occurred, and it's retracted all the way back to the A1 pulley level. For the superficialis component, we come up here, we see the retracted laceration here near the level of the A1 or the A2 pulley, and we see that the distal part of the superficialis, the laceration, is near the level of the PIP joint. So you can see that in addition to detecting these, it's very nice to show the degree of retraction, because then the hand surgeon can figure out where they need to maybe make their puncture or small incisions to fish out the retracted ends of these tendons to attain a primary repair. I mentioned that you can get also these fibrocartilaginous injuries involving the volar plates. This is a skeletally immature patient playing football, grabbed a jersey, had an injury involving the finger, and you can see that the primary abnormality here is that we don't see the volar plate in its normal morphology or position. It's torn and it's flipped here proximally, just deep to the flexor tendon apparatus. Shifting over to the dorsal aspect, the extensor tendon injuries also have a zonal description. And as with the flexor tendon zonal description, it tends to be different for the finger than it is for the thumb. So know that there are some differences. Generally, I'm going to describe where these injuries are, and maybe parenthetically I'll put in there what zone it is, but I don't just report these as a zonal level in keeping with the rest of my reporting philosophy, where I make sure to describe things accurately and maybe only use classifications parenthetically. This is a hyperflexion injury, which is the most common mechanism for these extensor injuries. And the axial T1, intermediate weighted, and post-GAD images, you can see that the central slip is thickened. There's increased signal intensity. There's abnormal enhancement. In the sagittal plane, when we look at the central slip, you see the thickening, the increased signal intensity. It's not a retracted full-thickness tear of the central slip, which would result in a gap and may result in a wavy sort of appearance. So this is just a partial thickness tear. strain of the central slip. When you have a retracted full thickness tear or laceration, you're going to end up with a gap where there's non-visualization. So here's the MR microscopy, here's the central slip in the adjacent digit. Here, there's just complete non-visualization of it due to a full thickness tear of the central slip. The reason this diagnosis is important to make is that this is a surgical indication for these patients and important for reestablishing extension of the digit. There's several different reconstruction techniques. They're fairly complicated, actually. This one's called a Matev central slip reconstruction. But pretty uniformly, this represents surgical disease. More distally, you have this entity of the mallet finger. On conventional radiographs, when we pick this up, it tends to be an avulsion fracture of the extensor insertion on the dorsal aspect of the base of the distal phalanx. But you can also just rupture the extensor tendon distally. This is a 58-year-old male who developed an acute mallet finger as a result of a golf swing in his non-dominant hand as a result of hitting something other than the ball, hit the ground or a root or some thick grass or something. And on the sagittal T2 star weighted image, you can nicely see the flexor tendon apparatus. Here, when we follow the extensor tendon apparatus, though, there's a gap here from a retracted rupture of the tendon distally here. So this is an example of a mallet finger without an associated avulsion fracture. In the axial plane, not surprisingly, you're just going to get, here's the normal extensor tendon distally here, central slip, and you just get non-visualization, fluid signal intensity in the acute setting on the intermediate weighted image. And here's the T2 star weighted image. Again, there's normal appearance distally. Here, it's just completely absent out near its insertion. As I mentioned, sagittal band injuries, usually we're going to pick up secondary signs of where the extensor tendon apparatus is subluxed either radially or ulnarly at the level of the metacarpal head. So this is a case, it was a domestic dispute. The guy got in an argument with his wife at the dinner table. She came after him with a steak knife. He was trying to protect his face, and he got stabbed in the back of his hands a couple times and actually got stabbed in the back also. The guy had a thoracic epidural hematoma from getting stabbed. But in the hand, you can see that he's got this subluxation of his extensor mechanism here radially due to a penetrating injury right through the sagittal band. This is the PD image without fat suppression, and this is with fat suppression. I always tell my buddies, when they get married, you got to decide right away, do you want to be right or do you want to be happy? And obviously this guy wanted to be right, and it didn't go well for him. Other patients with these sagittal band injuries, here's a 46-year-old male, had a twisting mechanism of injury involving the hand with acute onset of pain and swelling of the index metacarpal phalangeal joint. Has two injuries here. First of all, notice that the extensor mechanism is not centered on that metacarpal head. It's subluxed here radially due to an injury involving the ulnar sagittal band. There's also a problem here with the radial collateral ligament. Notice it's thickened, increased signal intensity. Here's the sagittal band rupture, and there's the subluxation of that extensor mechanism relative to the metacarpal head. T2 star weighted image, ulnar-sided sagittal band injury, subluxation of the extensor mechanism, radial collateral ligament tear. In the coronal plane, we can nicely see, here's the radial collateral ligament, there's the tear of its metacarpal attachment on T2 star weighted imaging. Why is this important? This also is surgical disease. Okay. The most common procedure that's done is something that's called a kettle camp, where basically if you have a tear that goes through the sagittal band, they just go in there and do a primary repair if possible. Shifting over to pulley injuries, most common in rock climbers. Interestingly enough, at the other end of the spectrum for non-contract, non-collision sports, we see this in bowling. So rock climbers and bowlers, those are about the only two patient populations I've seen these in. This is a series from the Hungarian orthopedic literature in which they looked at a series of rock climbers, pulley strains in 40% of them, pulley ruptures in 60%. Fortunately, 90% of these pulley injuries in rock climbers were single pulley ruptures, multiple pulley ruptures in only 10%. Why is that important? Usually if it's just a single pulley that's torn, they can be managed conservatively. If you get multiple pulleys involved, especially if it's both A2 and A4, these patients are going to require surgical reconstruction. This is a nice kind of spectrum of pathology that shows how important the development and evolution of dedicated coils has been to orthopedic imaging. These are all patients that I've seen over the last 20 years. Initially, this is a rock climber with a pulley injury, and 20 years ago all we had were kind of larger surface coils, and the way that I would diagnose these pulley injuries is this bowstringing, this secondary sign. Notice the flexor tendon apparatus in the sagittal plane is not contacting the volar surface of the phalanges here. So even though I couldn't see the pulley injuries directly, I know they're there just because of this secondary sign. But then this is a case more like about 15 years ago with a dedicated wrist coil, also in a rock climber. But now I can directly see, here's the A2 pulley, and the small finger is intact. But in the ring finger, you can see it's ruptured, and you got fluid signal intensity kind of extending through it. The ulnar component's intact, it's a radial component that's torn. But here now, with dedicated wrist coils, we could directly see them. And now with MR microscopy coils, it gets even better. So here we can see that one component of the A2 pulley in this rock climber is stretched out. You can see the early bowstringing, the separation of the flexor tendon apparatus from the phalanx compared to the normal adjacent finger. And then here's the rupture of the ulnar-sided aspect of the ulnar pulley, of the A2 pulley at this level that we can directly visualize with MR microscopy. I mentioned that bowling can also do this. It tends to be, when you grab one of these bowling balls and the hole is too tight for your finger and it's kind of stuck on there and kind of does this distraction sort of thing when you go to throw the bowling ball. So this is an acute bowling injury, an A2 pulley rupture on T1 weighted imaging. Here's the intermediate weighted sequence with fat suppression. There's the ruptured A2 pulley, all the fluid and edema and the soft tissues surrounding it. Here's another bowling injury. This is one where a single pulley lesion may represent surgical disease because of interposition. Notice that not only is the A2 pulley ruptured here, but it's interposed here. It's flipped in between the flexor tendon apparatus and the phalanx. So it's not going to have a tendency to heal with just conservative management. You can see there's a little bit of bowstringing that's starting to develop here. In the thumb, you can also get pulley injuries. These are much less common. This is a 33-year-old male who had a fall on an outstretched hand that included a scaphoid fracture and decreased flexion and a lot of pain in the thumb. And you can see the bowstringing of the flexor tendon apparatus. Look how far out the flexor tendon apparatus is here from the phalanges, the proximal phalanx, here in the thumb as a result of pulley injuries, A1, oblique. These are the two most important ones, but all three pulleys were ruptured in this particular patient. Here's the bowstringing seen in the sagittal images associated with this thumb pulley injuries. Not surprisingly, 3T has value here in these small parts imaging. You can see the numbers here. Sensitivity about 90%, specificity 100% for pulley injuries. So the field strength here obviously can be traded in for high resolution imaging in small parts like the digits. We'll finish up here in the last couple of minutes just with soft tissue trauma in the fingers. So here we've got non-radiopaque foreign bodies which result in foreign body granulomas or abscesses. Infection in and around the nail bed can develop as a result of trauma, so paronychia, eponychia. You can get abscesses as a result of penetrating trauma, and then also intraosseous epidermoid inclusion cysts or epidermal cysts in the bone as a result of penetrating trauma. So a couple of examples. This is a patient who was hiking in the desert, was from the Midwest, picked up a piece of cactus on the trail to show his wife, realized he shouldn't have picked it up. It was stuck to his hand. He went like this, and the piece of cactus promptly flew off his hand and embedded in the dorsum of his foot because he was wearing sandals. About a week later, he comes in with all these abscesses in his hand and in his foot. So we were asked to do MRIs in both to locate where the cactus needles were. And you can see these little cactus needles sitting here. You can see the little abscesses that are forming around them. Here's a contrast-enhanced image, and you can nicely see the cactus and the inflammatory reaction that's starting to form around these little cactus needles. In a felon, in this case due to penetrating trauma, it's essentially a soft tissue abscess. So that term refers to a little soft tissue abscess that's in the distal pulp of the finger. So you can see here it's fluid signal on the T1, fluid signal intensity on the intermediate weighted fat suppressed sequence, and then you have rim enhancement around this fluid collection. I think this was due to from a thorn or something, gardening, that had punctured the finger. And this is an example of a soft tissue abscess in the distal pulp of the finger referred to as a felon. Last case is a 25-year-old female that had penetrating trauma that involved the nail bed as a result of a bolt puncture through the nail bed. Had been treated conservatively but started to develop pain over the next couple of weeks and months involving the distal tip of the finger. On conventional radiographs, there was a lytic lesion involving the distal phalanx. On the axial T1 weighted image, you can see this well-circumscribed geographic lesion that's involving the distal phalanx. There's not much surrounding perifocal bone marrow edema. It's contiguous with this disruption and a little bit of deformity involving the nail and the nail bed from the penetrating trauma. On the intermediate weighted sequence, it's fluid signal intensity. Here on the T2 star weighted image, you see right where the penetrating trauma occurred. And this is that cystic lesion forming in the distal phalanx. And this is an example of an intraosseous epidermoid inclusion cyst due to prior penetrating trauma. So that's it for me. Summarize, in 2014 for injuries of the finger, you should be using the dedicated wrist coil at the very least. If you've got these little microscopy coils, this is a great application. Keep in mind the unique anatomic considerations in the fingers, including the fibroosseous tunnel. Great for a broad spectrum of pathology, and if you really pay attention to generating high image quality and reports that reflect the unique anatomy and pathology and even unique lexicon in the digits, I think you'll find that you can really increase your referrals from your hand surgeons. Since this is my last lecture, I'd like to thank Bill and thank John for the invitation to speak with you again this year. For me, this is not just a profession, but it's a passionate hobby also, so I enjoy sharing my experience. Thank you very much for your attention.